شغل زياده يعني ناقش كثير مواضيع حقيقه مهمه بعضها. And arthroscopic bankart repair principles, tips, and tricks. Now, the first key for success. So, everyone who does surgery wants to have a successful surgery. And the first key of success is to know when not to do the surgery. When not when to do the surgery. So, who would answer when not to do the surgery?
إذا conservative treatment.
No, limitations. Surgical limitation. The patient needs surgery, but will not do surgery. Why? What are the limitations?
يعني ممكن يعني he needs يقول مثلا في عنده stiffness. ظهرت له مثلا.
Okay. Limitations. عبد المؤمن.
If you don't have good instruments or proper
Setup. Either you don't have good setup or experience. So don't do the surgery because you will be very satisfied if your surgery is successful, but you will be frustrated if your surgery fails. So the first point to have success is to know when not to do the surgery. The second point, we have to define the pathology and to try to restore the anatomy as possible. And this is our aim because the best is our anatomy. Proper surgical techniques. So to have success, not only to have only proper surgical techniques, you have to know the limitations and diagnose the pathology and correctly that or that. So what are limitations? Setup, experience, so knowledge. So we have to know what are our limitations and not go to hurry to do a more sophisticated surgery. Indications. So important to know what type of instability we have. So I think you all know the standard of classification, the border system, where in type 1 there is trauma and there is structural defect. In type 2 there is no trauma and maybe a structural defect. In type 3, no trauma and no structural defect. So most of our surgery here is type 1, where there is trauma, unilateral, there is Bankart, and the patient needs surgery. And here surgery is indeed. Now, if you see type 2 here, what we call it is equivalent to ambry, where there is some lesion or some structural lesion. So you may have a patient with no trauma, but he has ligamentous laxity, or minor trauma anywhere here in the limb, minor trauma, and he has Bankart lesion, and he has ambry, multidirectional traumatic dislocation with minor trauma causing Bankart. In this patient, there is a rule for conservative treatment and surgery may be included. This is very important. In type 3, never do surgery. Surgery is contraindicated. So if you do surgery here, you will have failure. So decision making, proper diagnosis is very important. So most of our patients here. Now, when you decide surgery, there are principles about this surgery. The basic or the first principle is to identify the pathology. Pre-op diagnosis, and all that discussions here now we made is just from history to diagnose what you have. So, how can we identify the pathology? First, we have to know about the pathology, the pathoanatomy, and to look for them. So, in instability, we have either labral, or we call it capsulolabral, and I think we discussed that, the capsule is the labral. We could have only capsular lesion, and we could have a bony lesion. So we have to look for that. Capsulolabral, capsular, or bony defect. Labral, we could have Bankart, anterior labral tear, reverse Bankart, posterior labral tear, or we may have also slat lesion. Capsular, it may be just plastic deformation of the capsule intersubstance tear or stitching. Capsular laxity, especially type 2 or 2. And may have Hagel lesion. You see, this here talk about this. Here, MRI is more advantageous to diagnose the Hagel lesion. Now, it could be bony, and we know either the humeral head side, like head sac, and it may be engaging, like in this case. This here told us about this. The patient has very difficult reduction, so we believe that, or we suspect that he has an engaging head sac lesion. This is reverse sac. Here could be in the glenoid side, either Bankart, bony Bankart lesion, or from repeated instability, he may have a glenoid bone defect. So these are some types of pathoanatomy, and you can differentiate here. Here is a Bankart, simple Bankart. Here is a bony Bankart. Here is a Bankart with separation of the periosteum or the capsule, and it's called Arthroscopic lesion. Here ulcer lesion. This is very important. When you go in this scope, you see all the lateral and the capsule structure medialized. So if you don't do proper mobilization, your surgery will fail. Blood lesion, and here the Hagel lesion, which is the humeral side avulsion of the humeral ligament. So you have to know these pathoanatomy and to look for them in your imaging before you go to do the surgery. X-ray limited rule, but it can show sometimes the bony Bankart, specially used, or it can show the Hill-Sachs lesion. And so we need to evaluate the patient properly with more sophisticated imaging techniques like the CT scan, CT arthrogram, MRI, or MRI arthrogram. Now, you see, all of us use the MRI, but you have to know that MRI has limitation in the diagnosis of Bankart lesion or slab lesion, and in the evaluation of the bony lesion. You see, it has limitations. So the best is to do CT arthrogram or MRI arthrogram, but they are invasive. In our practice, we don't do it routinely. So this gives us the importance of doing what? Proper diagnostic arthroscopy intraoperatively. So how can this imaging help you in decision making? And this is the point. If you are not expert enough, don't go to operate for an ulcer lesion with a huge Hill-Sachs, medium blessage. So if you see this patient, refer to a more expert surgeon or ask for help. This is important for success, because you can do very horrible surgery and hours, and this may end with failure. So this helps you in making a decision to go for arthroscopic or open surgery. Why open? Why open surgery? Because we have limitations in arthroscopic technique. And this is an example. If you have this lesion, separation of the capsule from the humeral side, how can you manage arthroscopy? So you can do it open, or you need a very highly demanding arthroscopy. So if you don't have enough experience, so go for these cases with open. Now the second limitation, Hill-Sachs. So if you have huge, large, engaging Hill-Sachs, so in this case, you need to do remplacement, which is making this lesion from intra-articular bone defect to extra-articular, and this needs experience. So if you don't have this enough experience, you ask for help or refer your patient. Don't start with this difficult cases. Now the other limitation of arthroscopy is when you have bone defect in the glenoid, and Dr. White talked about this. It's like a tear shape, and if you have it like inverted tear, so you have to replace this bone defect bilaterally. So from your evaluation, you can decide to go for open surgery. Other limitation, what's this? Yeah, so this is also limitation of arthroscopic technique. So if you don't have enough experience, you cannot do arthroscopic capsular shape, you can do it open. And in the literature, open has superior result than the arthroscopic. The third principle, patient was, and I think this was discussed. And here the point, if you are doing semi-sitting position, you need arm holder. And the advantage of this, that you can change to open surgery. And this is the point Ziad told us about. If you are doing laterals, you have to properly evaluate the bone before the surgery. But if you do a deep chair or sitting chair position, you can do your arthroscopic diagnosis and then decide to do one procedure. The disadvantage, the possible disadvantage of this position is the visualization of the inferior glenoid joint. But this is possible if you have enough experience how to deal with that. I think this is not a problem. Lateral, the problem that you cannot do dynamic examination, and the second, that it's consuming, time consuming, and do change to open section. Principle 4. You have to have proper visualization of the defect, the pathology. And I'll show you here, this may need to shift the scope to the anterior or anterolateral borders to have proper visualization. And this is an example. You see here, this is the scope from posterior. And you see there is defect in the anterior adenoid with retraction of the labral tear. And how much this adenoid defect? Who can tell me? Looks large, yeah? But look here, how large is the defect? When you go to the superior, to the anterior superior portal, you see how huge is the adenoid defect. So you have to see the pathology, not only to see it by image, by proper scope. Here, large Bankart lesion. You see it descending from superior. So here, hill sacks, and this one trick. You see the hill sacks is that to push the arm anteriorly when you are from behind. And you see how huge here is the hill sacks lesion. Another, this is a case, one of my patient I treated many years ago. What do you see? What's this? Hagel lesion. And you see, if you don't go, to the inferior capsule and switch the scope and change the direction of the camera, you cannot see this Hagel lesion. This is a huge. This one of my patient presented to me 6 months after the injury. I did for him lethargy. This is very important to diagnose by scope. Let's make this test. This is a patient present with recurrent dislocation 6-5. What can you see from the MRI? Maybe here a Bankart, I don't know. Let's see here head sacks lesion. And if you see here the MRI, there is no much adenoid defect. And this is the importance of CT. Like Ziad said, sometimes you cannot see the bone by MRI. But when I did scope, you see here how huge is the head sacks lesion, and it's engaging anteriorly with the anterior adenoid rim. And if you switch the scope, you will see how huge is the adenoid defect. You see, this is the first spot. There's a large anterior adenoid defect. So in this case, we have engaging hill sacks with anterior adenoid defect. So the treatment is so you see how the X-ray hill sac is large. So it's very important that our plan can change according to the finding of proper arthroscopy. So here, what's the lesion? Who can tell me? Anyone see anything? You see everything is okay?
Yeah.
Everything is okay till now. I go down, check for Hagel. Is there Hagel? Let's see. No Hagel. So this is normal scope, but the patient has instability. What's the problem? So we have to switch the scope and examine from here. So this is by inspection. You see, the adenoid is good, the labrum looks good. Anyone see something here?
I think you have to grow.
Yes, exactly. This is the point. So it's not enough to see. It's like in our clinical examination, but wait, and here you have to grow. You see? But what to grow? This is our tree of diagnosis. So you have to evaluate, know what they are going to do, and then do proper diagnostic arthroscopy. And in areas, suspicious areas where you think there is the lesion, you have to probe. And here the lesion, you see, this is concealed labral tear. And if you go back to the MRI, you see here there is a perilabral cyst. So this imaging gives us idea what to do, and we have to check intraoperatively. This is the rule of proper diagnostic arthroscopy when treating instability. Principle 5, know your portals, and I think this was discussed, but the important here the anteromedial portal we detect a little inferior, and here the anterolateral portal we make it a little superior, so we can change our portal and use the posterior. The lateral we don't use in instability surgery. This is here what I did actually. I mark the anterior medial, anterior lateral, the lateral, posterior, and posterolateral. I connect them, and when there is suspicion that I may change my plan to letter J, I mark the incision for that. This is very important in the shoulder console. Everything will change. Okay. Now, you see, the best is when you do the portal is to use a needle. You know? And here in the cannibal course, I bring the needle with me because this is very important. It gives you the guide where the angle, the direction. And look here how many puncture I did, okay, just to reach this. Okay, now I can reach the pathology, so I am satisfied with this portal. So this is another example. This is one of my patients did for Randasa. You see how many puncture I did? I'm not comfortable with this. Now I change the needle. Not good, now good. You see? So you have to check the needle that you are in good angle. And here you see, I mark my incision here, my portal here, but I did it inferior. I mark my posterolateral here, but I did it a little bit more posterior. So this is according to the needle, the guide by needle. Here, portal, the basal portal, maybe for slap repair. G portal is just for suprascapular, we don't use it for stability. There is a portal which is the deep anteromedial, which is used for arthroscopic bankart. Principle 6, stepwise technique. So all that keys for success. And one of them is a stepwise. So you have to do proper labral mobilization. Don't fix, just fix. You have to mobilize the labrum. The second, you have to refresh the bone, because we need biology. If you suture skin to skin or not, here you have fresh bone, and this is very important. And we have then to fix, so to fix the labrum. And here you have to have different techniques using knotted or knotless ankle, and how to pass the sutures. I'll show you now. Now the first step is to mobilize the labrum. After I diagnose the pathology, I have to mobilize. This is dissector, which is very nice. You can use it. And mobilize till you see the subscap fibers. You see here the subscap fibers. Mobilize till I see the subscap. Now the labrum will come to this place. Now after that you have to refresh the bed. And here very important, don't do full decomplication. Put the glenoid. You don't to make a glenoid effect. So you can use only shaver or use curve. Okay? And the second point that you can use this rasp. And this is helpful. I use always both. Now how to pass the sutures, and this is discussed direct or indirect. And I'll show you here. I use for the most inferior ankle, I pass the suture by using this instrument. And this is good because this is the second duration which can pass and retrieve the suture. You don't do 2 steps, just 1 step. It's available in Jordan. Now, after passing, this is one technique. This is another technique, how to pass the suture, direct passing. So we have this instrument and we have this instrument, rhino or liver or robotic. This is important. This is a case where I did Bankart and Feiha. And here, I pass the suture, but I won't tie them before I do the anterior. I finish the anterior repair because it tightens these spaces. This is very important in this text of the technique. Now, this is indirect technique using lasso. So you pass the wire, then retrieve and pass the suture. This is indirect way of passing the sutures. See, the sutures come. Now, how to fix knotless or knotted? This is how we make a knotless fixation, knotless ankle. You see, after refreshment of the bed and mobilization, we use this instrument, pass and the suture. And after that, when you retrieve the suture, you make the cinch loop. You know the cinch loop. You pass the suture in the loop of the other, like this. I'll show you here. You see, this is the loop. Yeah, the suture pass now around the labrum and get the loop. But make sure that the loop is in the outer side, not in the inner side, because I want to plane the labrum in front. Now, this is one trick I use. where to put the anchor after passing the suture. I mark, just put the suture treatment, hold the suture and get the label and define where is the point to put your anchor. Just you can make a mark on the top. And after that, you can drill. See here, here's my mark. So I make the hole just above the mark because the suture will go to the mark. You got it? Now you drill. And after that, you can fix. You see how you can fix it? Tap the anchor and then cut the suture. It's very important to be precise. And one trick here is don't make this when using the guide, don't make it close to the anterior margin, the anterior limb, because this can cause a fracture. So you have to go posterior, maybe 2 or 3 millimeters up. Don't make it just on the limb, because this can cause a fracture. Now, this is the knotted anchor. After the same, I put here the video that the importance of refreshing the bone, because we want it to heal, okay? You make the refreshment using rasp and shaver, and after that, you put the anchor. And how to pass the anchor? Either direct or indirect, to pass the sutures. And here one important thing is you insert the anchor, it should be buried, not prominent. Make it more buried, it's much more than make it prominent, because this can cause arthritis. Now, after you put the anchor, you pass the suture, and here in this case, I use direct passing, you see. Direct, this is the liner, and I use the knot pusher to bring the suture to the passer. This is one trick also. After that, you retrieve the suture from the bottom of the cannula, and after that, you can make the tie. And this, I think, in the workshop, we will show you how to make a good tying technique, because we want the loop security and the knot security, because we want this stable after finishing our surgery. And how to make, which is the post and which is how to switch the post, because the post is the one you put it. So we want the knot on the outer side first. We want the knot in the outer side, not on the cartilage side. And here when you finish the other anchors and you see the final design. So this is very important to have a stepwise technique, and you make the portals what you want. So if you need accessory portal, don't say I'm making 2 portals. As much you want, you can use. For example, in this case, I use 4 portals. It's a case posterior instability under mid forehead, also subscapular disease. So as you want, you can use portal, but you have to do proper, good job. So take home message. Operative success needs proper education, proper diagnosis and identification of the pathology, and a good stepwise technique. There are some limitations of arthroscopic surgery, so shift to open or ask for help. You should have backup plan. And start, enjoy your surgery. So start with simple cases, don't carry in more difficult cases, and build up your arthroscopic technique experience safely and gradually. Thank you.